All right. Thank you guys for joining us. And ladies and gentlemen, welcome. Today we have the privilege of learning about one of the most significant yet often overlooked aspects of health, sleep apnea. And who better to guide us through this journey than our esteemed speaker, whose decades of dedication and expertise are unparalleled. Currently, he is the coordinator of the Sleep Disorder Center at North Kansas City Hospital, a position he's held since 2016. He's been at the hospital since 2006. His credentials speak volumes. A registered respiratory therapist since 1979, a registered polysomnographic sleep
You got it.
technologist. I knew I was going to slur that up. Since
Everybody does.
1998. With a wealth of experience and a passion for improving patients' lives, our speaker is here to deepen our understanding of sleep apnea and its impact. Please join me in welcoming John McCurdy. Thank you so much, John, for joining us today.
Well, you're very welcome. Thank you for having me.
Yeah.
Hello, everybody. We're going to discuss sleep apnea. I don't know, obviously, how many of you know what that is. So we're going to get started off here with just get going with the definition here of what sleep apnea is and how it affects people and some of the treatment options. So sleep apnea is an event, multiple events that occur while the person is sleeping. That person will have frequent awakenings throughout their sleep, which is caused by an irregular breathing pattern that goes throughout the whole entire night. The apnea affects about 20% of the population, and men are more affected and receive a diagnosis of sleep apnea before the age of 50. Children have sleep apnea. Of course, women have sleep apnea, just not to the extent that men do. And when we look at somebody and we go, oh, yeah, they've got sleep apnea just because of their body habitus, that doesn't necessarily equate to the person having sleep apnea or not having sleep apnea. So a very obese individual might have sleep apnea, whereas a very obese male, and a very obese female might not have sleep apnea. So it's the old adage, you cannot judge a book by its cover. When a diagnosis of sleep apnea is made, the physician is going to look at the complications that sleep apnea causes and will tell the patient about those complications. The first one is excessive sleepiness. The individual usually takes short naps without wanting to take a nap throughout the day. And they can last anywhere from 5 to 10 to possibly over an hour. This is quite aggravating to individuals because they want to stay awake. Even at work, sleep apnea would cause the individual to become incredibly sleepy and they would nod off. Truck drivers, air traffic controllers, train engineers. It affects the whole gamut of the population and what people do for their living. And it is a severe impairment to their overall health and to their overall wellness, put it that way. Now, the breathing periods typically last, for our definition, they have to last for at least 10 seconds in duration. They can last a lot longer, believe me. I have actually seen an individual not take a breath for 2.5 minutes while monitoring the individual, and it was very catastrophic for that individual. The body reacts in ways of having irregular heart rhythms, such as premature ventricular contractions, AFib, aflutter, high blood pressure, and these would cause heart damage and heart failure. And then there's the sudden cardiac death, which typically a person would be asleep and they would throw an abnormal heart rhythm and their heart would not start again. So it's a very, very serious condition to have. Strokes are very high on individuals with sleep apnea if they don't get it treated, which is horrid, horrid, horrid. So it's a condition that if you have sleep apnea, or if you suspect you have sleep apnea, or your spouse, you need to have that addressed because it is life-threatening. Um, there are various types of sleep apnea. Uh, we classify them as the type of airway breathing. The first one is obstructive, and that's where there is absolutely no air moving by the patient's body. And it is simply caused by the narrowing of the throat in this area here. If you can see my chin, there you go. And it literally can collapse during sleep, especially when they're sleeping on their back. An individual with heavy snoring um, typically does have sleep apnea because if they have a long, prolonged history of snoring, well, that just makes the airways back here swell and become enlarged, which causes greater propensity during the night, especially as I said earlier, while they're sleeping on their back, to have an obstructive event. There are what we call central sleep apneas, and that's simply where there are no signals coming from the brainstem to have the person breathe. Okay, this is usually we see these in people with post strokes. You could have a cardiac, or you could have a lesion on the brainstem. Even post heart surgeries, if the phrenic nerve is damaged at all, it can lead to central sleep apneas. And then the last one is just what we call hypopneas. And those are simply episodes where the person is moving air. They're just not moving enough air to sustain their oxygenation level during the night. So all these three types cause detrimental effects to the patient by the frequent awakenings during the day, the heart issues that I told you about, and the ramifications of such. Does anybody have any questions on that? Okay.
Doesn't look like it right now, John.
I apologize.
No, you're fine. I said it doesn't look like anyone has
Okay,
any
good, very good.
questions
All
yet.
right. So let me go to back here a bit. Okay, so how does an individual get diagnosed and treated for sleep apnea? The first step would be to see your primary care physician and make a complaint that, hey, doc, I'm snoring at night, I'm tossing and turning, I'm horribly tired during the daytime, and I'm falling asleep at places I shouldn't be sleeping. And my blood pressure is up, and I wake up with morning headaches. Those are all classic signs of an individual with sleep apnea. So the physician would dig a little bit deeper in terms of the possible causes of sleep apnea. There's a hereditary portion of it, which if a patient's family, mother, father, possibly even grandparents had sleep apnea, their chances of having sleep apnea are greatly increased. It doesn't mean they're going to have it, it's just greatly increased. Once a physician has everything documented that he or she needs to have a sleep study ordered, then a sleep study is ordered through our centralized scheduling department here at the hospital. And then we would set them up with a date and time that they would come to the sleep lab here to be diagnosed and treated with sleep apnea. When we look at somebody at night when we're sleeping, we're seeing all kinds of information in front of us. We're monitoring, obviously, we're monitoring their breathing, their oxygenation level, and we're also monitoring their brainwave activity. And this brainwave activity tells us what stage of sleep they're in while they're sleeping. And some people are more prominent to sleep apnea in what we call REM, sleep that's rapid eye movement, and people associate this with the breathing, with the dreaming state. Actually, you can dream in all stages of sleep. You just have a better recall if you would wake you up in REM. They are positional. They could be sleeping on their back and have horrid sleep apnea, but the minute they flip to their side, it's gone. So we monitor them with wires on their scalp and on their face with two elastic bands, one around their tummy, one around their chest. They're going to wear a finger probe on the finger to measure their oxygenation level. And then we're also going to monitor to see if they're having any aberrant leg twitches, which we call periodic leg movement syndrome. And that's just where the person has the need to move their legs all the time, well before they go to sleep, and or the bed partner would complain that they kick during the night. So a lot of wires, a lot of documentation, and with all those gadgets, that's how we diagnose sleep apnea. Now, once we get the sleep apnea diagnosed, then and that's at the main lab. And I do want to go back just a little bit here later to talk about home sleep studies, okay? But right now I'm just going to continue with the treatment. The treatment, the most common treatment of sleep apnea is with positive airway pressure. And that's delivered by a machine at the patient's bedside, connected by a length of tubing to a mask that the patient wears while they're asleep. And there are nasal masks, full face masks, just mouth masks. So there's various types of masks that we can attempt to treat the patient with. The CPAP stands for continuous positive airway pressure. And then there's also the modality called BiPAP. CPAP is where the pressure that the person inhales and exhales against is the same. Whereas BiPAP, it's a two-level process. The inspiratory pressure is greater than the expiratory pressure, and people find this modality more comfortable usually than CPAP. But the patient has to meet certain criteria before we can just kick them to BiPAP, okay? Obviously, as I stated, sleeping on your back is a negative feature sometimes. So you want to sleep on their side. You can get a body pillow and lean against. We used to make T-shirts with two tennis balls sewn in the back of the T-shirt, a little bit higher on the T-shirt from the small of the back. So obviously, when the patient rolls on their back, they're not going to sleep that way because that wakes them up, and then they go back on their side. It sounds like a good idea, but a lot of people move from a back to side, back to side. So even if they have the tennis balls there, they're still awakening, having to move to their side. There are also oral appliances, usually set up by a dentist. And what these appliances do, it's typically a two-part device that adjusts the jaw forward with the little screws with the screwdriver, and the patient can do that themselves. What they would simply do is, hopefully, if they had a bed partner, the bed partner would say, "Yeah, you're not snoring," and the patients themselves are waking up feeling fairly refreshed. The drawback with oral appliances is that it only will treat patients with sleep apnea who are awakening less than 20 times an hour. So that's a limitation on those. And also, the patient has to have intact molars on their uppers and lower teeth in order for the appliance to fit properly. The most, how do I say this? The most, not severe, but the most, I'll just say, painful way is to literally have your jaw broken by surgery, and then that jaw is moved forward, and then you're wired shut. And when the jaw is moved forward, then that opens up the airway. It's like if you've ever had CPR training and were taught to lift the chin up, and that opens the airway. Well, this surgery with moving the jaw forward does that for us, but it's very painful. There's a long period of time before you can get the wires removed, but it is optional. I don't know of anyone in this area that actually does those type of surgeries, and to be quite honest, it's kind of outdated. There's also surgery techniques that they go in and they remove the tonsils, and then the little flap of skin that's hanging in the back of your throat. If you're looking in the mirror, the little flap of skin is called a uvula. So the surgeon would go in and remove the uvula, remove the tonsils, and then take 2 to 3 millimeters of excess tissue out of the back of that oral airway. It used to be thought of as a cure all, but it doesn't work with everybody. Um, what we would do would be we study the patient after that surgery was performed to see if they're still having the events. And unfortunately, in my experience, I've had to wake more people up at night and having them put back on CPAP than the patient, the doctor thinks. And it's very uncomfortable when you have to go into a patient's room and say, I'm sorry, we got to put the mask back on you, where they went through all this surgery and the cost. So it's not a very pleasant situation for either of the technologist nor the patient. There's also devices that called TAP. They're called tongue advancement. Uh, how do I put this? I can't put the right word in my mouth. Anyway, it's a device that they wear, and your tongue goes into this area of the device. And when your tongue is not allowed to fall back into your airway, then the sleep apnea has gone away or has been greatly reduced. I don't know if you've seen the uh, advertisements on a device called Inspire. You see it on TV where the patient is currently on CPAP, but then they want to go to Inspire, and they say it changes the world for them. You have to qualify for Inspire, and it's a surgical process where they put a like a little pacemaker in you, and then they run wires to the base of your tongue, and then when they program the device, we just simply look to see if they're still having more abnormal breathing events, and then we would just slightly increase these small doses of voltage so that those are abolished. Uh, as I said, there's qualifications. The patient has to have a trial of CPAP and fail it, either by saying, I can't tolerate it, or it just didn't work. Um, so we just can't have a patient come in and say, I want Inspire. We don't do the surgeries here. The KU Medical Center does the Inspire surgeries, and then we follow up with them here as well as KU to see if the voltage is correct in order to abolish their sleep apnea events. I mentioned earlier about a home sleep study, and these are called HSTs. And what these are is devices that a patient comes to the lab, and we teach them how to apply the device to them. And then they go home, and that night they put that device on themselves. What it does, it simply monitors their breathing effort, uh, the volume. We don't measure the volume, but we have a nice flow tracing that associates itself with the breathing events, and an oximeter probe on the finger. We don't monitor any brainwave activity. We don't monitor any leg kicking activity or anything like that. The patient wears it for at least 6 to 7 hours. We prefer 7. And then they bring it back the next day. We score out the data for the physician. And we also make sure that the data was correctly collected by either the patient taking the device off inadvertently, or they just didn't sleep long enough that we could get a definitive diagnosis for their sleep apnea with that device. But there are devices that work very well. As I said, the kicker is patient sometimes takes a finger probe off, takes the device that measures your airflow out of their nose. So if that happens for an extended period of time, then obviously we have to repeat the study again. We don't charge for that second study. We just have we ask the patient if they want to try it again. If they don't, then they would come here to the lab, and then as I told you earlier, all the wires and so forth, we would put them on. And if something did come off during the night, then our technologist that's watching the patient would go in the room and put them back on. So after a person's diagnosed here in the lab, we will go in after we have documented enough abnormal breathing events to cause the person to awaken at least 15 times an hour. Once that documentation has been obtained, then we go in and fit the patient with the mask, start them on a low pressure CPAP. If they can't tolerate it, then we kick them to BiPAP, and hopefully the BiPAP will be tolerable to them. And as they have those abnormal breathing events, we simply remotely increase the pressure incrementally, very slowly, all right, until we see that the airway is open, the oxygenation level is maintaining an adequate number, and hopefully the patient feels a lot better the next morning. So, with that in mind, the CPAP machines themselves, we do not deal with the dermal medical equipment. The physician's office that orders the sleep study would call a company that sets up home equipment in the patient's home. And hopefully, after a month or so, the physician will get what we call a download on the data just to make sure that everything is working in terms of airway staying open, oxygenation level staying high. And that, for us, it's above 88%. So the kicker with the need for documentation for the overnight for the sleep study, I'm sorry, for the CPAP to be worn, Medicare wants the patient to at least wear it more than 4 hours a night for at least 28 days of the month. If they cannot do that, then they have to go through some more testing, and hopefully that would resolve the issue. That's going to get kind of convoluted, especially if the patient's been on CPAP and now they, for some reason, have not worn it for several months. The compliance data shows that they're not wearing it. Then we would have to start all over again, and that would be starting with a diagnostic test and coming to the lab to retreat the patient's apnea. Once all the data has been accumulated, the physician will get their results in about 3 weeks. It's a long process. We do not score our sleep studies with a computer. We manually score each sleep study. We look at 30 seconds of time during the scoring of the study to monitor what stage of sleep they're in and how often they awaken. And then we scrunch it back down to a 2-minute or 3-minute screen where we can look at the breathing pattern. And so it takes a while. It takes almost 2 hours to score what I refer to as a clean study. If there's a lot of artifact or the patient's moving around a lot, it makes it a little bit longer to get scored out. So that's the reason for the delay. A lot of people ask, is it going to take that long? And I say, yeah, unfortunately, it does sometimes. So that is the gist of sleep apnea. Any questions that anyone has?
We do have a few questions, John.
Sure, go for it.
One, does the winter season, is that a factor to increase sleep apnea because of the heater being on?
Not necessarily. The only one of the drawbacks to the cold weather is, as you know, there's not enough humidity in the air for your lungs to be happy about. So the humidifier that is supplied with the CPAP machine has to overcome that, and that would cause the humidity level that the patient is receiving to be higher. But in terms of the actual cold or the temperature or anything like that, no, it really doesn't.
Okay, very good. Thank you. Got a few more. What
Sure.
if you don't have any symptoms of sleep apnea, but you still have sleep apnea?
Not only are we looking at sleep apnea, but we're also looking at those patients who, what we call, are hypersomnolent. They are tired for absolutely no reason. The next day, they don't have any apnea. They don't have any leg twitching. We come in and test them, and we have them stay overnight with us. And then the next day, We're going to have them stay with us for all day, and we will run a series of 5 naps that last anywhere from 25 to 30 minutes. And with those naps, what we're looking at is how fast did the patient fall asleep after you average up all those nap times. Typically, an individual should, depending on what source you want to quote, uh, be to sleep within 8 minutes. Anything past 15 to 20 minutes, then it becomes problematic. During the testing too for those MSLTs, we're looking to see if there's any abnormal movements while the patient is sleeping. We're looking for any kind of RAM intrusion, REM, what I talked about earlier. And if the patient does have RAM intrusion upon the 4 naps, well, 2 out of the 4 naps, the diagnosis of either hypersomnia or narcolepsy, which can be given to the patient. Narcolepsy is when an individual just falls asleep out of the blue, doesn't know when he or she fell asleep, they sleep, and they can sleep for long periods of time. Another interesting thing about those patients is that when you look at their sleep during the night, you see on the readout that they wake up frequently, very, very frequently. So it's not a consolidated sleep. With the REM intrusion upon that, then the narcolepsy and or hypersomnia diagnosis can be given to the patient. The treatment for that would be a stimulant, Adderall, Ritalin, and there's some new products on the market, Xywav, that's out there that do quite nicely, especially the Xywav. The Adderall, you really have to watch it because it will affect the patient's heart rate and blood pressure, as will Ritalin. But the Xywav is a very good medication, and it really helps individuals get a solid night's sleep.
Wow, that's really in depth there, John. We have a few more.
Oh,
You talked about restless leg,
mm-hmm.
but this individual said they're not sure if that is definitely a part of sleep apnea or could it be a separate thing? Just
It's
wanted
a
some
sep-
clarification.
it's a separate thing. It's where they have the random leg movements that are just moving all night long. And we count each one of those leg movements, and then we tally them up. There has to be a scale there's a scale that we follow. They have to have so many leg twitches within a certain amount of time for us to classify them as periodic leg movement. Um, every time a patient wakes up, usually, I'll caveat that, usually they will have a leg twitch associated with that. So not only are we looking at the breathing pattern, we're looking at the leg twitching. And then we have to differentiate, okay, did they wake up because of the leg twitching, or did they wake up because of the breathing is shallow or non-existent, thus causing the leg to twitch, which awakens the patient?
Wow.
And a medication is used for that uh, uh, problem.
Do you have any idea what the price is for a home sleep apnea study?
An individual insurance company, uh, how do I put this, negotiates with the hospital to what the price is. Um, I hate to say what it is really, so I will tell you it's probably right around $8,000 for the overnight study, but if the insurance will cover a majority of the cost. Uh, and the overnight study going into the day study, the MSLT, that's about $10,000. So these aren't cheap. These aren't
Mm-mm.
cheap at all. So that's why we are very adamant about when we do a study, we're getting all the necessary information for the patient and for the physician so they don't have to come back again and go through this process.
Oh, yeah, I imagine. How about the home sleep study?
Home sleep studies, they're less than the overnight study in the lab. The amount, I can't even quote you amount because it varies so much between insurance carriers and what the hospital has negotiated with them. If I was going out on a limb and say they're probably close to $3,000, $4,000 still.
Okay.
They're not cheap.
Mhm.
And the Inspire, that's a hefty cost. That's about 30 grand for the surgery and the implantation of the uh, device. And then plus they have to have the in-lab sleep study to verify that the voltage is correct enough to keep the airways open. So that's a real expensive one.
Wow. Wow. Do you feel like the Inspire is safe?
It's safe. Yes. It doesn't interfere with pacemakers, other pacemakers, or anything like that. Uh, I will say from the experience, it takes a while for the individual to get used to it because your tongue is getting zapped, and it's. Of course, I've never had Inspire. I use BiPAP every night when I sleep, but it's a process where they have to get used to that feeling, and some people just it takes them a long time to get used to that tongue getting zapped because it's uncomfortable. I'm sure I've like I said, I've never had one, but um, that does draw back a little bit on the adequacy of the study. Do I think it works? Um, it works for some people. That's about the best way I can put it. All
Okay.
right. When
Yeah.
you hear the advertisement on TV says it eliminates, does the same thing for BiPAP. No, there are other issues that come up and cause issues. Okay.
Not that cut and dry, is it?
No, it's not.
Okay.
It is not.
We got another question here.
Mhm.
Says my husband has used CPAP for 24 years. He is now 86 and sleeps for long stretches of time throughout the day and evening. He goes to bed as early as 8:30 and gets up after 6. Is age possibly more a factor at this point than his CPAP needing adjustment?
Possibly be because we know that elderly they awaken more frequently at night than people of a younger age, and they just awaken. Sometimes their stimulus response for outside sounds or movements by the bed partner or even their movements would awaken them and keep them awake for a longer period of time. So the age factor and in terms of frequency of awakening, it does increase. Uh, as long as the patient is trying to wear the mask and is feeling good with the mask and not tired during the day, is good. Unfortunately, there are patients who have both what I refer to as hypersomnia and sleep apnea, which is a very difficult thing to live with. I myself have narcolepsy, which I believe I said earlier that you just fall asleep spontaneously throughout the day, and I have sleep apnea. So I get treated with medication for my narcolepsy, and have to wear the BiPAP at night. So as I get older, which I'm getting older way too fast, in my opinion, I'm sure my sleep will not get too much better than what it is right now, and hopefully it won't get any worse. But that's about the best way I can answer that question for you. And I'm not trying to be vague or dodge the question. It's a difficult question when we're talking about elderly. They're just a different species of their own to deal with in terms of sleep.
Right. Okay. Is it true that some people have their days and nights mixed up?
If you're fatigued enough, yes, you can lose track of what day it is. You can even lose track if it's night or day. Now, the latter, I've really never encountered somebody not being able to differentiate between the daylight and nighttime. But the previous one where you lose track of time and day, yeah, that can happen if you're fatigued enough. Yeah, you can get confused. But then, you have issues that also interfere with like dementia and those type of issues that can cause that more readily than anything. But um, the sleep is causing lack of sleep does cause them to lose track of time and sometimes day or night.
Okay. Well, can sleep apnea cause dementia or memory loss if left untreated?
No, well, if left untreated,
Yes.
I can't uh, I can't answer the dimension the dementia part of it. But in terms of lack of sleep, you bet if they're not treated, they're going to be awakening a lot, which lack of sleep, you're fatigued, you're grumpy, depression can sometimes sneak in there. And if the patient's family has a history of dementia, it would increase the risk of dementia in that patient.
Wow, we've got some great questions here. This participant says, I was just recently put on a CPAP for low oxygen, and most often the machine shows 0 events or maybe 1 event per hour. The
Okay.
most events I have had in a month is 5. Will this amount require me to use the CPAP long term?
That's a very low number. And um, as long as the person, the 5 events isn't getting any greater than 10 on the CPAP, and they're currently wearing CPAP or not, I forgot. They're currently
Yes,
wearing?
currently on a
Yeah.
CPAP.
uh, they might have to wear it for an extended period of time in their life. Yeah. The oxygenation issue, we also will test for that as well. Once we get the person's sleep apnea under control, if we see that the patient needs oxygen in conjunction with the CPAP or BiPAP, we will add the oxygen at that night. And of course, the physician would then order both oxygen therapy in conjunction with positive airway therapy.
This participant uses CPAP, but they wonder if BiPAP would be better. How do you determine which?
Mhm. It's very simply, in my humble opinion, BiPAP is much more comfortable. But once again, you have to kind of jump through some hoops in order to get that person on BiPAP. Personal opinion, I would just as soon use BiPAP versus CPAP in everybody. It's just more comfortable. But the hoops that a person has to jump through, they're going to have another sleep study to show that they're tolerant of CPAP and so forth. What we do at the lab is we have patients that come in and they don't like their CPAP. They want to go on BiPAP, and or the physician has ordered specifically BiPAP, even though the patient's still on CPAP. We just simply ask the patient, do you really like CPAP? And we shake our heads no. And so once
Mhm.
the patient says no, they don't like it, then we just document patient finds CPAP intolerable, move to BiPAP.
Okay, very good. So once diagnosed with sleep apnea, and sleep studies are sleep studies needed every so often. This individual, their CPAP machine was set up initially 10 years ago. Does
Mhm.
it need to be recalibrated after such a long time frame, or do they need another sleep study? How often would that happen?
If the machine is working adequately for the patient, and if the patient is not complaining of any sleepiness during the daytime, the machine still should be working. However, 10 years, that's a pretty long time to have a machine. Okay. Their lifespan, I would say, is right about 10 years. So, in a roundabout way, I would say, yeah, you'd probably want another study. And you would have to go to the physician. You'd have to document the reason why you just say you want to try CPAP and start BiPAP, I'm sorry. But then again, that all has to be documented by the physician. And that face to face physician has to occur within, I believe it's 6 months. So once the patient sees the physician, they have to do that study within a 6 week, 6 month period of time. If they don't, then they call us and they would call us and say, hey, I haven't seen my physician for over a year. I need a new machine. And what do I do? And the next question we ask, do you have a report of a compliance report in terms of how many hours a night are you wearing it? And is the number of abnormal breathing events high or low? So that's all taken into consideration. The big thing now is patient has to be seen by a physician either on the video conference or in person. And the physician has to document why. the person needs a new machine and or needs a sleep study before we can even do the study. And that's not our mandate. That's insurance policies that companies mandates. They mandate that, actually started from Medicare, of course. But it can be a very aggravating situation. But 10 years, I would get another sleep study just to make sure a machine is working adequately, because they're prone to not deliver enough pressure at times.
All right, very good. Well, anybody have any more questions? Looks like that might be it.
Well, good.
Well, that was a wealth of information. Um, and I'd like to tell everyone who did sign up for this presentation that I will be emailing you a link. This presentation will be uploaded to our YouTube channel, so it can be watched again. And then you can also share the link to in your family or friends if you think that somebody would benefit from the information that John shared today. You could surely share that link with them, and you can check out the vast library that North Kansas City has on the YouTube channel. A lot of good information, mental health, nutrition, heart health. There's just a variety of issues or a variety of topics out there. It looks like one person said thank you. That's great. And the other person says, yes, it was a great talk. Thank you. And I will be seeing my doctor after what I've learned today.
But I do want to add, Miss Jody, that if they ever want to call and talk to any of our technologists or talk to me, our number is area code 816-691-5096. And we're here Monday through Friday. We are not open during the day on the weekends. But don't hesitate to give us a call. Anyone you talk to here knows a lot, just like they should. But we will answer their questions for them, and we don't pacify people. We tell it like it is.
Good,
So
good.
people need to have adequate sleep in order to feel healthy and in order to prolong their life as possibly.
Okay. Excellent. I will pass on that phone number when I send
Excellent.
out the email link. Thank you
Excellent.
so much, and everyone stay warm out there.
No, yes, please stay warm and be safe. All
All
right.
right.
Well, thank you all
Thank you
for
very much.
joining. Appreciate it. Thank you, Miss Jody.
Thank you. Bye bye.
Bye-bye.